that means what are the risk factors what we usually see? These are the diabetes, hypertension and other obesity, patient is a smoker, alcoholic and other familial conditions of cardiomyopathies. So the treatment starts even at the stage A. That means patient is having who is at risk of the heart failure, and we are going to target such patients and we are going to treat adequately the hypertension. It may be the hypertension control or diabetes control or the CVD risk factor control, or giving the lifestyle modification for obesity and other agents. So especially when we are dealing with diabetic patients, start SGLT2 inhibitors at the earliest possible stages. That means when as soon as we diagnose the patient in to be a diabetic, start the patient with SGLT2 so that we can prevent the patient going into the advancement of the heart failure. Okay, and from then we move on to the stage B, where the patient is having the risk factors and also the structural heart disease problems, but still the patient is asymptomatic. So even at this stage we target such patients also and give the adequate treatment before and prevent the patient to go into the advancement of the heart failure. And stage 3 and stage 4 we have already seen. Patients with stage 3 C is the patients having symptomatic heart failure condition, and stage D is the one where the patient is symptomatic in spite of getting the adequate medical therapy, GDMT, which is. So this is the Framingham heart failure criteria, major and minor, which is 2 major or 1 major plus 2 minor is a diagnostic feature of heart failure. This is a symptom based simple criteria where we can get to know whether the patient is having a heart failure or other causes of the heart failure. And this is the classification already been dealt. See, when here this is more important to be discussed here. If the patient, these are classified as 3. Initially it was 2 classification, where the patient was basically classified as the patients with reduced ejection fraction where the EF was less than 40, and preserved ejection fraction where the EF was beyond 50. And there is another set of patients where there is mildly reduced ejection fraction where EF is between 41 to 49. So these are different set of patients who we have to deal separately. And newer incorporation of this classification is patients with improved ejection fraction, where patients, these were already compromised patients with EF of less than 40. They have on treatment, they have improved, and now their EF is more than 40. So these are also the different set of patients what we are dealing with. So this is the classification and trajectory, how each set of patients progress. They can either stay in the same class or they can progress to a different class. But the notably thing what we can see here is the patients with preserved ejection fraction, where they can stay in the as a preserved ejection fraction, or they can worsen to go into the mildly reduced ejection fraction or reduced ejection fraction. So that means that when you are seeing a patient with diastolic heart failure, what we usually write in the echo report, like patient is having class 1 diastolic dysfunction, stage 2 diastolic dysfunction or stage 3 diastolic dysfunction. So it doesn't mean that patient will stay like that only. These patients can worsen to become mildly reduced or reduced ejection fraction. Their EF can fall based upon their particular condition. So they need to be closely monitored. Doesn't mean that today we are giving the patients a proper treatment, and doesn't mean that they don't worsen their EF. This can happen on either vice versa. So these are the diagnostic testings what we usually order for, usually the ICU profile. But what is the important notable thing here is the NT-proBNP, which is going to be not only a diagnostic criteria but also has the prognostic importance. Prognostic importance because once we start the patient on GDMT, we will know the patient whether he is taking proper medication or not, whether he is getting the adequate therapy according to his clinical condition, and whether he is improving or not. A person with NT-proBNP of higher values, that means when initially they have started with the higher values and patient is still on the higher values of NT-proBNP, you should know that patient is not going to go better. Patient is going to have a recurrent multiple hospitalizations, multiple drug therapies, and these are the patients usually succumb to the heart failure disease. And also one of the important things what we usually see is if you are suspecting any cardiomyopathies, so you should also be in a position to order the cardiac MRI, where of course amyloidosis and other cardiomyopathies is not that rare also. So you have to have in the mind that patient can be suffering some cardiomyopathy, and you have to order a cardiac MRI if we need. And there are infective causes also, and if you are suspecting of any inflammatory conditions, ANA profile is also being indicated. And there are, because we have already discussed about the NT-proBNP, there are other non-cardiac causes of the other cardiac causes of the NT-proBNP and also the non-cardiac causes of the raised NT-proBNP. Not only heart failure, other conditions like ACS, pulmonary embolism, myocarditis, LBH, hypertrophic cardiomyopathy. There are n number of causes where we can see that the NT-proBNP not only elevates due to heart failure, but also the other conditions which we have to keep it in mind so that we will not jump into the diagnosis that patient is having a heart failure and we'll start the treatment. There are non-cardiac causes of the raised NT-proBNP also, where you can recent ischemic stroke and patient with subarachnoid hemorrhage, patient with liver disease, patient who is a documented COPD patient or patient with a CKD. So there are severe anemia and severe metabolic acidosis, thyrotoxicosis and diabetes also, uncontrolled diabetes also is known to increase the NT-proBNP. So this is the differential diagnosis which you have to keep it in mind when we say that a patient is having an raised NT-proBNP levels and not his symptoms is not actually merging to the NT-proBNP values. So this is the slide showing the overview of the heart failure. Here, as we have already discussed, this is the guideline directed medical therapy for across the various spectrums of the heart failure. The treatment usually starts at the stage A, where a patient is already at risk. You should start the SGLT2 inhibitors as soon as we diagnose the patient to be diabetic. And stage B, where is also a patient is having risk factors along with the structural diseases, structural heart disease. So all the green ones are the class 1 indication. That means the patient must get all these treatments in the fullest possible tolerated doses. Class B patients need to require SGLT2, MRAs, beta blockers and ARNIs. If the patient is not tolerating ARNI, AC inhibitors followed with ARBs can be tried. But usually the ARNI is the better one if the patient is able to afford. Then class C and class D. Again here in this we can, in the first column we can see this is of course, in the first column is the, we can, in heart failure with reduced ejection fraction, all the 4 pillars of the heart failure are must. That means that patient should get an ARNI and beta blocker, MRA and SGLT2 inhibitor as a must for in the maximum tolerated doses. In the best possible ways he should get it, and loop diuretics can be used if the patient is already on the fluid overload, and if the patient is having a mildly reduced ejection fraction, only the loop diuretics are being indicated. The other drugs like the ARNI or SGLT2 or beta blockers or MRS, they all come under class 2A and 2B. So there is no much role of these drugs, and if the patient is having a preserved ejection fraction, someone with the symptoms and only echo report is showing only the diastolic dysfunction of grade 1, grade 2, grade 3, that patient only is going to benefit from the loop diuretics. Other drugs like beta blockers, AC inhibitors, ARNIs or SGLT2 inhibitors, they come under class 2A and B. And there are additional medical therapies along with the GDMT which are going to benefit for these patients. If the patient is hypertensive, you please correct it properly, and if the patient is having a cardiovascular disease, please do revascularization in the best possible way. And if the patient is having and other especially the reduced ejection fraction category, if the patient is having a heart rate beyond the beta blockers, if you are not able to control the heart rate around 60 to 70, even in spite of giving the maximum tolerated dose of beta blockers, you can take use of ivabradine, which comes under class 2A indication. Other drugs like vericiguat, what we have already discussed, and digoxin and pufas, these are the drugs that comes under class 2B indication. So this is also the overview. Initially we will start with the 4 pillars of the heart failure. There are specific diseases where we have to tackle, excuse me. Yeah. If the patient is having fluid overload, please start him on the diuretics, and ECG, please make a note on the ECG. What is his ECG like? If it is normal QRS complex, so nothing much can be done for that patient in terms of intervention. But if the patient is having a wide QRS, then we have to know what is the morphology of the QRS. If the patient is having an LBBB morphology with a QRS duration of more than 150 milliseconds, then he can be given a CRTD, which comes under class 2A indication, class 1 indication for them. And if the patient is having an LBB morphology with a QRS duration of 130 to 150, then CRTD can be given for such patients also. Then the treatment would be under class 2 indication for them. And if the patient is having atrial fibrillation, please treat accordingly, give anticoagulation. You can give digoxin and pulmonary venous ablation. The digoxin and pulmonary venous ablation comes under class 2A indication for them. And if the patient is having and the patient is if the patient is having the advanced heart failure symptoms, please we have to go for any medical supportive, mechanical supportive devices, and like LVADs or Impella, or if temporary or permanent, based upon the requirement of the patient. And if the patient is still not improving, then we can go plan for a transplantation in such patients. So these are the various drugs trials, the dosages which are being studied. In Lapril, we already know it is a age-old drug which can start with smallest dose of 2.5 mg BD, and it can go up to 20 mg BD. The Ramipril, usually we give 2.5 mg to 5 mg BD. And Arni, which is starting from 25 mg BD to we can go up to 200 mg BD. Bisoprolol, carvedilol, we already are well versed with the dosage of each drug, and probably we can start accordingly. But the recent advances is the Vericiguat. It is a drug which can be given with an OD dose 2.5 mg initial dose. You can increase the dose, double the dose, add 2.5 mg for every 2 weeks till the patient gets the maximum tolerated dose of 10 mg per day. So these are the indications for ASCD and CRT. As we have already discussed, if the patient, first you have to give the optimal medical therapy with the GDMT, and if the patient is still symptomatic, still LV dysfunction after 3 months of therapy, if the patient is still symptomatic, with or without symptoms, if the EF is less than 35 and the QRS duration is more than 150 milliseconds, LBBB and morphology and more than 150 milliseconds, go for CRTD. And if the patient is having an LBBB of morphology of LB with QRS duration of 130 to 150, it is still CRTD can be indicated, but it is class 2A indication. And patient can improve, such patients, and cannot improve if it is a QRS duration of more than 150 and RBBB morphology. Still you can go for CRTD in such patients too, but still it is under again under 2A indication. And if the patient is having an LV-EF of less than 35 with history of ischemic cardiomyopathy, if the patient post-MI, then you can help such patients by advising for an AICD, automated intracardiac defibrillator, where it comes under class 1 indication. If it is non-ischemic cardiomyopathy, AICD comes under class 2A indication. So if any patient post-MI, severe LV dysfunction, in spite of treatment for 3 months with GDMT, if the patient is not improving, such patients are the ideal candidates for AICD. And you will definitely help the patient, especially if the patient is young enough and with a history of sudden cardiac death in the family. These are going to be the ideal patients for AICD. And heart failure in special settings, so we are usually worried this is the regular patient without any comorbidities. What of the patient if the patient is having a CKD? So in such patients, from stage 1, stage 2 and stage 3, entire stage 3, all these 4 pillars of heart failure are indicated. That means that in spite of RNA giving rise to increase of hyperkalemia or increase the serum creatinine, and MRAs increasing the serum creatinine, all this taken into consideration, still from stage 1 to stage 3 of CKD, all the 4 pillars of heart failure are indicated. And stage 4 of CKD, only that SGLT2 inhibitors and MRAs and omnicamtiv mecarbil and the iron, Vericiguat and digoxin. Only these 4 to 5 drugs are indicated in stage 4. And stage 5 of CKD, no matter what drug you use, the patient is going to be getting nothing out of it. So probably no drug is going to help with stage 5 of CKD patients. And heart failure in AF patients, if the patient is having AF and that is causing for heart failure, please control the rate. If at all possible, you can control the rhythm also. If the patient is symptomatic, that means the patient is having any sudden cardiac giddiness and syncopal attacks, then you can go for pacing, dual chamber pacing. And if the patient is having any, if you want to treatable causes, you feel like, you can go for pulmonary venous ablation. That is again class 2A indication. In the heart failure in special settings, that is the PPCM, this is the peripartum cardiomyopathy, where patient is having the entire picture will be of heart failure, that too in a recent mother. Either she is carrying in the later part of the delivery or the early 5 months of delivery, peripartum area. That is the condition where the patient is having symptoms with full-blown symptoms of heart failure, and usually the such patients are patients with reduced ejection fraction. And what do we do with such patients? Here the risk factors would be like African American race and patients with preeclampsia, elderly females, and multiple gestations, and hypertension, already patients with hypertension, and uncontrolled diabetes is also one of the risk factor. And what do we do with such patients? If the patient is still pregnant, that means patient is not delivered, then we have to give we have to avoid ARNIs and ARB and MRAs, and we have to only settle with loop diuretics and beta blockers and hydralazine isosorbate mononitrate. And is such patient, and you can also give digoxin. And if the patient is post delivery, you can give the as per the full guidelines of the heart failure. And after pregnancy, what would be like the delivery for the subsequent and one thing one should be keeping in mind that when the patient is postpartum, patient should be the lactation should be suppressed, and the patient should be discouraged from giving the breastfeeding. Under any cost, we should not encourage the patient to give breastfeeding to the baby if the patient is diagnosed as PPCM. And once the patient is been treated well, and there is every chance of recurrence in the next pregnancy. Out of 100 patients diagnosed with PPCM, only 80% they recover and 20% they don't recover. They either stay with the same ejection fraction in spite of your best efforts, and there are every possibility, very few patients they worsen. And in the setting of heart failure in anemia, it is a vicious cycle where a patient with anemia, patient can have anemia with heart failure, and anemia can precipitate heart failure. So already heart failure patient can have anemia during the course of treatment, or an anemia itself can cause heart failure, and that is a vicious cycle which we have to break. Anemia, there are multiple causes of anemia. Usually they don't feel, anorexia is one of the most common cause. Patient don't feel like eating because of the bloating sensation, and one of the other causes is like decreased absorption and increased blood loss, GI loss, causing iron deficiency. And because heart failure we have already seen, this is a chronic inflammatory state where there are increased amount of cytokines, and because of which there is a decreased metabolism of iron. So there is a decreased absorption from the macrophages and decreased release of iron from the hepatocytes, and that also causes the worsening of the anemia. And there is also, because of the coexistence of CKD, there is some amount of CKD, there is a decreased production of the erythropoietin, also requiring anemia. And if the patient is having a heart failure, full-blown heart failure, of course there is a fluid retention and hemodilution that cause also anemia. So in such patients, HB, the guideline should be like, you have to always correct the patient, at least a minimum of 12.5 grams should be there. You can do if the blood transfusion, if it is in the acute setting, whereas the severe anemia, you have to do the blood transfusion. And iron transfusion in severe cases, if the HB is less than 7, so obviously we have to give iron, parenteral iron. Oral iron therapy, if the patient is having mild anemia. Erythropoietin stimulating agents also, they are of course used in CKD patients, but in spite of the patients is not having a CKD, the other beneficial effects of erythropoietin stimulators they decrease the infarct size, of course, and they decrease the hypoxic injury, they prevent the myocyte apoptosis, and they mobilize the endothelial progenitor cells irrespective of the HB. So probably in the future there should be certain studies being done in the use of erythropoietin stimulating agents in the future, what is their role in the heart failure irrespective of the HB status. Probably in the future we will see in such studies. And acute setting, most of this heart failure treatment in the acute setting is going to be similar to the chronic heart setting. Only the thing is you have to add drugs like vericiguat at the later stage of that latest part, and you have to use more of loop diuretics apart from using the MRS. And clinical, what is the clinical, when do we call the patient is having advanced heart failure? So if the patient, we call the patient to be having an advanced heart failure where you have the symptomatic patient, in spite of getting GDMT treatment, still the patient is in class 3 and class 4 of heart failure, and still the patient is having EF of less than 35 and the isolated RV dysfunction is there, like patients with arrhythmogenic right ventricular dysplasia, and non-operable severe valvular diseases and non-operable congenital abnormalities, and patient who is having high NT-proBNP irrespective of your treatment. So these are the patients whom you think that and a patient is having severe decreased mobility, that means that 6-minute walk test is less than 300 meters. So such patients, we label them as the advanced heart failure, and for such advanced heart failure we think of the interventional management of heart failure, where if the patient is in having an acute setting, that means patient is in ICU and you are not able to control maintain his BP in spite of your best possible efforts. Such patients we consider giving a temporary mechanical support by if at all few days, 1 to less than 7 days, you go for IABP, intra-aortic balloon pump, and if the patient is not, if you are thinking that patient will not recover even within one week, so probably you have to go for Impella, which will give you a little more time, maybe 2 to 3 weeks, but it is more costlier, and of course, we know arterial ECMO is also one of the option, of course with higher morbidity and mortality rates. If the patient is having a long-term mechanical support, if he is needing a long-term mechanical support, patient can be considered for LVADs and heart-made artificial hearts. So what are the patients who to be considered for LVADs? So these are special set of the patients who are in the advanced heart failure. They don't usually a persistent LVEF of less than 20. In spite of your best possible efforts, and the patient is having more than 3 hospitalizations in the 1 year. So these are the patients and requiring a more common amount of inotropes, either temporary or permanent. So such are the patients who are candidates for LVADs recommendation. Of course, the cost is going to be one of the constraints, which is very costly. And what are the preventive strategies? So always identify the patients who are at risk and tell them, counsel them, and treat accordingly. What are the supportive therapy? Supportive therapy of heart failure. Of course, heart failure therapy is not just about drugs. It is multimodality and involving various departments, and rehabilitation is one of the component. Patient should be encouraged to have a normal physical activity and try to have the exercise as much as possible. Restrict the fluids to less than 1.5 to 2 liters per day, and healthy diet should be encouraged. Ask them to stop the alcohol completely, and immunization is one of the major component of the heart failure therapy, where flu vaccine and pneumococcal vaccine is to be indicated, and advice to the patient, and stop smoking and any other recreational drugs, and travel and driving can be done depending upon the patient's condition. So newer drugs has already been discussed. Versigouat, this is a oral soluble guanyl cyclase inhibitor. It increases the sensitivity of nitric oxide and decreases. There are multiple causes. So absorption usually by oral tablet, 93% oral absorption, and distribution is by plasma bound, 98%. Metabolism is in liver, and excretion is in excretion. It's drug stays for 30 hours in the body, so it is taken as once daily dosage. But the important part of it is if you are giving it with the long-acting nitrates and PDST2 inhibitors like sildenafil, you have to be little more cautious and rather avoid it. It cannot be given with pregnancy and lactation. Other specific conditions, like the patient has an already hepatic condition where the child's pux 1 and A and B, they can be safely given. Child's pux C cannot be given. Versigouat cannot be given, and versigouat can be given even in the renal impairment as long as the EGFR is more than 15. If the EGFR is less than 50, avoid this drug completely. And omecamtiv mecarbil, it is a drug to be given in the low ejection fraction in a long-term basis. It is a direct activation of the myosin. So there are few trials that shows that it is really useful in certain population, especially in CKD. Afinirenone is the newer non-steroidal mineralocorticoid, like the spironolactone and eplerenone, what we have been using since ages. This finolone has been the recent addition to it. The only advantage is it doesn't have the other side effects like gynecomastia, and it stays for a shorter duration of time, lesser amount of hyperkalemia when compared to that of the spironolactone and eplerenone. And vaccines in heart failure, we have already seen vaccines are inflammation is being the major component. So pneumococcal vaccine and flu vaccine has been indicated as per the guidelines from 2010, they are being indicated. So transplantation indications, so when the patient is diagnosed as advanced heart failure, we have to give it as a try, provided the other systems of him is working normally and he is not an addict. and the patients who are considered for end of life, here it is a patient is having a progressive decline in the mental and the physical health, and severe heart failure symptoms and poor quality of life, and frequent admissions, heart failure is been ruled out, heart transplantation is been ruled out, and patient is having a cachexia, and such patients is being labeled as end of life, and nothing can be done much about it. Give them proper rehabilitation, whatever better you can do for that patients. And thank you for patient listening.